Mechanical ventilation is a life-saving intervention for patients who are unable to breathe on their own. Ventilators use positive pressure to deliver oxygenated air into the lungs so that gas exchange can occur. As I'm sure you are aware, this is a complex topic, but it must be understood by respiratory therapists and medical professionals who care for patients in critical condition. The good news is you're in the right place because this video will provide a comprehensive overview of mechanical ventilation and the basics of how ventilators work. So, if you're ready, let's get into it. As previously mentioned, mechanical ventilation involves the use of a machine to help a patient who is unable to breathe spontaneously. Therefore, it is indicated for patients who are unable to maintain adequate ventilation. Ventilation is the process of taking in oxygen during inhalation while removing carbon dioxide during exhalation. When a patient is unable to do this on their own, a ventilator can be used to assist with or completely take over the ventilatory process. Now let's talk about the indications. Some of the most common reasons why a patient may require ventilation include insufficient oxygenation. When a patient is not receiving enough oxygen, it can impact the functionality of tissues and vital organs of the body. Mechanical ventilation can help deliver oxygen to the lungs, which is then distributed throughout the body. Insufficient ventilation. When a patient is not removing enough carbon dioxide from their body, it results in increased acidity of the blood. Mechanical ventilation helps the patient remove carbon dioxide during exhalation. An acute lung injury. This is an injury to the lungs that occurs from an acute event such as sepsis, pneumonia, aspiration, or trauma. Severe asthma. During an asthma exacerbation, the airways constrict and make it difficult to move air in and out of the lungs. This can lead to respiratory failure, which often requires ventilatory support. Severe hypotension. Conditions that cause extremely low blood pressure, such as shock, sepsis, and CHF, often require mechanical ventilation. Inability to protect the airway. When a patient is at risk of aspirating secretions into the lungs, they may require intubation and mechanical ventilation to protect their airway. And an upper airway obstruction. Conditions that cause upper airway obstructions, such as epiglottitis and laryngeal edema, can prevent patients from being able to move air into the lungs. Therefore, mechanical ventilation can help bypass the obstruction. In general, mechanical ventilation is indicated whenever a patient's spontaneous breathing is not adequate to sustain life. In such a case, a ventilator would be used to provide breathing support until the patient's underlying condition is reversed. Now let's talk about the contraindications. A patient cannot survive without adequate ventilation and oxygenation. Therefore, there are no true contraindications for mechanical ventilation. However, there may be some circumstances where a patient chooses not to receive mechanical ventilation, such as when they have a DNR order in place. This means that the patient legally wishes not to receive life-saving interventions. In these cases, the patient's goals of care must be respected. Now it's time to get into the weeds just a bit. The next topic we need to cover is the principles of mechanical ventilation. Practitioners must learn and understand the basic principles in order to administer support to patients in need. This includes the following: ventilation, which is the process of moving air into and out of the lungs. Oxygenation, which is the process of absorbing oxygen into the bloodstream. Lung compliance, which is the lung's ability to expand and contract. Airway resistance, which is the impedance of airflow through the respiratory tract. Deadspace ventilation, which is the volume of ventilated air that does not participate in gas exchange. And respiratory failure, which is the inability of the lungs to oxygenate the blood or remove carbon dioxide from the body. Each principle is important in determining the amount of ventilatory support that is delivered to the patient by the machine. And speaking of machines, what exactly is a mechanical ventilator? A ventilator is a breathing machine that uses positive pressure to deliver ventilatory breaths to patients who are in need of assistance. The machine consists of several parts that work together to generate positive pressure that helps force air into the lungs. Mechanical ventilation is an intervention that can provide short or long-term support while the patient's underlying condition is treated. It is often indicated for patients with cardiopulmonary disorders, but is also common in postoperative patients who are recovering from anesthesia. As previously mentioned, ventilators work by using positive pressure to deliver breaths to the patient. However, an artificial airway must be inserted into the patient's trachea before being connected to the machine. This process is known as intubation, which involves the insertion of an endotracheal tube through the mouth and into the trachea. Once the tube is in place, it establishes a link between the patient and the ventilator so that positive pressure breaths can be delivered. And one important thing to remember is that ventilators are not used to heal and treat a patient of their underlying disease. Rather, they are used to provide breathing support until the patient is stable and treated with medications and other modalities. Now let's talk about the benefits. There are many benefits for patients who are receiving mechanical ventilation, including the following. The first benefit is that it decreases work of breathing. The ventilator assists with the patient's breathing, which can help to decrease the amount of energy and work required for each breath. It maintains adequate oxygenation. The ventilator can deliver an FiO2 of up to 100% to help with oxygenation. It can also deliver PEEP, or positive end expiratory pressure, which is helpful in patients with refractory hypoxemia. It helps remove carbon dioxide. The ventilator can help the patient remove CO2 from their body with an increased respiratory rate or tidal volume. And it provides stability. The ventilator helps keep the patient stable, allowing medications and other modalities to reverse their underlying condition. The benefits of mechanical ventilation often far outweigh the risk, which is why it is such a common intervention in the field of respiratory care. However, there are some complications that can occur. Some of the most common risks and complications of mechanical ventilation include the following. First is barotrauma, which is an injury to lung tissue that results in alveolar overdistension caused by increased levels of pressure. Ventilator-associated pneumonia, which is a type of pneumonia that develops 48 hours or more after a patient has been intubated and placed on the ventilator. Autopeep, which is a complication of mechanical ventilation that occurs when a positive pressure remains in the alveoli at the end exhalation phase of the breathing cycle. Oxygen toxicity, which is a type of cell damage that can occur when a patient is exposed to high levels of oxygen for an extended period of time. And a ventilator-induced lung injury, which is an acute lung injury that occurs while a patient is receiving mechanical ventilatory support. With that said, these risks and complications can be minimized with proper care and monitoring by medical professionals. Next, we need to talk about the types. There are 4 primary types of mechanical ventilation, each with its own indications, settings, contraindications, and risks. This includes the following: positive pressure, negative pressure, invasive, and non-invasive. Positive pressure ventilation is the most common type. It's often referred to as conventional mechanical ventilation, and is generally what people are talking about when they say that someone is on the ventilator. This type works by using positive pressure that is greater than the atmospheric pressure to push air into the lungs. The air then fills the alveoli where the exchange of oxygen and carbon dioxide takes place. The next type is negative pressure ventilation. This type is not as common as positive pressure, but it may still be used in certain situations. It works by generating negative pressure outside of the thoracic cavity that is less than atmospheric pressure. As a result, air moves from an area of higher pressure or outside the body to an area of lower pressure, which is inside the lungs. Some examples of negative pressure ventilation include the iron lung, which is a negative pressure ventilator that was invented in the 1920s primarily to treat patients with polio, and cuirass ventilation, which is a type of negative pressure ventilation that is delivered through a tight-fitting garment that covers the chest and abdomen. Like I said, not quite as common, but still worth mentioning. And the next type is invasive mechanical ventilation. This type involves the insertion of an artificial airway into the trachea, which establishes a direct connection between the ventilator and the patient's lungs. There are two primary types of artificial airways that can be used: endotracheal tubes and tracheostomy tubes. An endotracheal or ET tube is a long, thin tube that is inserted through the nose or mouth and then passed down the throat into the trachea. A tracheostomy tube, on the other hand, is a shorter tube that is inserted through a small incision in the neck and then directly into the trachea. And finally, the last type that I want to mention is non-invasive ventilation. This is a type of ventilatory support that does not require the insertion of an artificial airway. Instead, it requires the use of a face mask that creates a tight seal over the patient's nose or mouth. This allows the machine to force oxygen-rich air into the patient's lungs using positive pressure. The two primary types of non-invasive ventilation include CPAP and BiPAP, which we will talk more about later on in this video. But in general, non-invasive ventilation is indicated to improve oxygenation and ventilation and to provide relief for respiratory distress prior to intubation and conventional mechanical ventilation. Moving right along, now let's talk about the ventilator modes. A ventilator mode is a setting that determines how the machine will deliver breaths to the patient. The characteristics of each mode determine how the ventilator functions. In general, there are two primary control variables in mechanical ventilation: volume control and pressure control. Volume control is a type of ventilation where the delivered volume can be set or controlled by the operator. Since the delivered volume is fixed, the patient's peak inspiratory pressure will vary depending on their lung compliance and airway resistance. The primary advantage of volume-controlled ventilation is that a set volume allows the operator to regulate the patient's minute ventilation. Pressure control, on the other hand, is a type of ventilation where the delivered level of pressure can be set or controlled by the operator. Since the delivered pressure is fixed, the patient's tidal volume will vary depending on their lung compliance and airway resistance. The primary advantage of pressure-controlled ventilation is that it protects the lungs from overinflation due to too much pressure, which prevents barrel trauma and ventilator-induced lung injuries. Now it's time to dive deeper into the different types of ventilator modes, including assist control, SIMV, pressure support, CPAP, volume support, control mode, airway pressure release ventilation, mandatory minute ventilation, inverse ratio ventilation, and high-frequency oscillatory ventilation. Each mode is different and has its own characteristics. This includes unique settings and how the machine will deliver breaths to the patient. We have a separate video that covers all the ventilator modes in more detail, so definitely check that out if you want to learn more. But for this video, I still want to cover the two primary ventilator modes, as they are assist control and SIMV, or synchronous intermittent mandatory ventilation. The assist control mode is used to deliver a minimum number of preset mandatory breaths by the ventilator, but the patient can also trigger assisted breaths. Therefore, the patient can make an effort to breathe, and the machine will use positive pressure to assist in delivering a breath. This mode provides full ventilatory support. Therefore, it is commonly used when mechanical ventilation is first initiated. This mode helps keep the patient's work of breathing requirement very low. The other primary mode of mechanical ventilation is SIMV. This mode delivers a preset number of mandatory breaths, but it also allows the patient to initiate spontaneous breaths in between the preset breaths. Since the patient is able to initiate spontaneous breaths, it means that they are contributing to some of their minute ventilation. Therefore, SIMV is indicated when a patient only needs partial ventilatory support. So now that we've covered the modes, next we need to talk about my second favorite topic, which is the ventilator settings. Ventilator settings are the specific parameters that are set on the machine in order to provide the patient with optimal ventilation. The most common types of ventilator settings include: first is the mode, which, as I just discussed, is the primary setting that determines how the ventilator functions. Next is the tidal volume, which is the volume of air that is delivered with each breath. The frequency or rate, which is the number of breaths that are delivered per minute. FiO2, which is the percentage of inspired oxygen that is being delivered to the patient. Flow rate, which is the rate at which a volume of air is being delivered to the patient. Next is the IE ratio, which is the ratio of the inspiratory portion compared to the expiratory portion of the breathing cycle. Sensitivity, which is the setting that determines how much effort or negative pressure the patient must generate in order to trigger a breath to be delivered. Then you have the PEEP, or positive end expiratory pressure, that is applied at the end of the expiratory phase in order to prevent alveolar collapse. And you have the ventilator alarms. All ventilators are equipped with alarms that act as safety mechanisms to alert caregivers when there is a problem related to the patient-ventilator interaction. Each ventilator setting has different characteristics that must be controlled or adjusted to determine the amount of support that is delivered to the patient. But before we can even input any modes or settings, we must first learn about the initiation of mechanical ventilation. This is a complex process that requires coordinated efforts of doctors and respiratory therapists. The decision to use mechanical ventilation is based on the patient's respiratory status and the underlying cause of respiratory failure, which means that you must learn about the initial ventilator settings. Once it has been determined that mechanical ventilation is needed, the operator must know how to properly input the initial ventilator settings, including the following. First is the mode, which the most common initial ventilator modes are assist control and SIMV. However, any operational mode will work when setting up the initial ventilator settings. Next is the tidal volume, which the initial tidal volume should be set at 6 to 8 milliliters per kilogram of the patient's ideal body weight. The initial frequency is 10 to 20 breaths per minute. The initial FiO2 should be set at 30 to 60%, or at the previous FiO2 that the patient was on prior to intubation, and this could be up to 100%. The initial flow rate should be set between 40 to 60 liters per minute. The initial IE ratio should be set between 1 to 2 and 1 to 4. The initial sensitivity should be set between -1 and -2. And the initial PEEP should be set between 4 to 6 centimeters of water pressure. The initial ventilator settings are set based on the patient's condition, but must be adjusted as their condition changes. For example, it's common for a patient to see an FiO2 of 100% when they are first intubated and placed on the ventilator. However, as the patient's oxygenation status improves, the FiO2 setting should be decreased. Switching gears just a bit, next we need to discuss artificial airways. Prior to being connected to the ventilator, a patient must first be intubated. As previously mentioned, this is the process that involves the insertion of an artificial airway into the trachea. And the two primary types again are ET tubes and tracheostomy tubes. Endotracheal tubes are inserted through the nose or mouth and then pass through the vocal cords into the trachea, where tracheostomy tubes are inserted through a surgical incision in the neck and directly into the trachea. But there are some secondary types of artificial airways that may be used in certain situations, and I want to briefly mention them in this video, so these include the following: oropharyngeal airways, nasopharyngeal airways, an LMA or laryngeal mask airway, king laryngeal tubes, esophageal obturator airways, esophageal gastric tube airways, esophageal tracheal combo tubes, and double lumen endotracheal tubes. Each type of artificial airway has its own advantages and disadvantages that must be considered when used during mechanical ventilation. But we cover each of these in other videos and articles on this channel and on our website, so definitely check those out if you want to learn more. The next topic that we need to discuss is the drugs used in mechanical ventilation. Some examples of the most common types include sedatives, analgesics, and paralytics. The use of drug therapy during mechanical ventilation is essential to achieve a desired patient outcome. That is why respiratory therapists must fully understand these drugs to avoid complications and prolonged mechanical ventilation. Sedatives are a class of drugs used to calm and relax the patient, reduce anxiety, and maintain the patient-ventilator interaction. Some examples include benzodiazepines, neuroleptics, and anesthetic agents. Analgesic agents are a class of drugs used to relieve pain and prevent discomfort associated with mechanical ventilation. Some examples include morphine, fentanyl, and hydromorphone. Paralysis can be achieved with neuromuscular blocking agents that are classified as depolarizing and non-depolarizing, depending on their mode of action. But moving right along, now we need to talk about managing patients on the ventilator. Ventilator management is the process of operating a mechanical ventilator and ensuring that it delivers adequate levels of support to the patient. This includes assessing oxygenation, ventilation, assessing lung mechanics, adjusting ventilator settings, reviewing the patient's progress, managing the ventilator circuit, managing the artificial airway, providing humidification therapy, implementing valve prevention strategies, providing nutritional support, maintaining fluid and electrolyte balance, and documenting the results. The primary goal of mechanical ventilation is to improve the patient's oxygenation and ventilation while minimizing ventilator-induced lung injuries. Therefore, as previously mentioned, it's important to make adjustments to the ventilator settings depending on the patient's condition. And another part of ventilator management is monitoring mechanically ventilated patients. Mechanical ventilation is a type of life support that requires close monitoring of the patient. This includes the process of assessing how the patient is responding to receiving positive pressure ventilation. The parameters that must be monitored when a patient is on the ventilator include their vital signs, breath sounds, chest imaging, chest movement, fluid balance, blood gas results, capnography, and cerebral perfusion pressure. Mechanical ventilation monitoring is a job duty of both respiratory therapists and nurses in the ICU. However, only respiratory therapists are responsible for making adjustments to the patient's ventilator settings. Another important topic that I need to mention is ventilator alarms. Ventilator alarms are designed to notify medical professionals when there is a problem with the patient-ventilator interaction. There are several types of ventilator alarms that you must know, including high pressure, low volume, high frequency, apnea, high PEEP, and low PEEP. Ventilator alarms can be visual, audible, or both, depending on the mode, settings, patient's condition, and the type of ventilator. Which leads to the next topic, and that is ventilator waveforms. Ventilator waveforms are graphical representations of the patient's breathing pattern that is displayed on the ventilator screen. The most common types of waveforms to assess a patient's ventilation include the flow volume loop, pressure volume loop, constant flow waveform, descending ramp flow waveform, pressure time waveform, and the flow time waveform. These ventilator graphics and waveforms can be used to assess the patient's lung mechanics, ventilator settings, and response to mechanical ventilation. And they should also help with ventilator troubleshooting, which is the next topic that we need to discuss. There are several things that can go wrong during mechanical ventilation. Therefore, ventilator troubleshooting refers to the process of identifying and resolving problems in the patient-ventilator interaction. Some examples of potential problems that can occur include bronchospasm, secretion buildup, airway obstruction, dynamic hyperinflation, a kink in the ET tube, a patient biting the ET tube, improper patient positioning, drug-induced distress, abdominal distension, leaks in the circuit, inadequate oxygenation, inadequate ventilation, improper ventilator settings, patient ventilator asynchrony, ventilator alarms that are sounding, a technical machine error, lung overinflation, auto PEEP, excessive PEEP, improper waveforms, obstructive expiratory valve, and apnea that is due to a disconnection. Oh yes, as you can see, a lot can go wrong. But again, respiratory therapists must be familiar with common ventilator problems and how to resolve them quickly and efficiently. This involves assessing the situation, analyzing the pertinent data, and finding a viable solution, which means that you must always remember the primary goal is to protect the patient by ensuring that they are receiving adequate ventilation and oxygenation. Therefore, if a problem occurs in the patient ventilator system, it may require disconnecting the patient and delivering breaths with a manual resuscitator until the problem is resolved. And the next essential topic that we need to discuss is ventilator weaning. Weaning from mechanical ventilation is the process of slowly reducing the level of support that a patient needs in order to eventually be able to breathe on their own. Weaning success occurs when a patient is able to tolerate spontaneous breathing for 48 hours following extubation without the need for reintubation. There are several factors that can contribute to weaning success, including the type of respiratory disease, severity, the patient's age, the presence of comorbidities, and the length of time on the ventilator. As previously mentioned, weaning failure occurs when a patient does not pass a spontaneous breathing trial or if there is a need for reintubation within 48 hours of being removed from the ventilator. In general, the greater the amount of time a patient is on the ventilator, the higher the risk of weaning failure. Therefore, patients with chronic diseases such as COPD are also more likely to experience weaning failure. And you must also be familiar with the weaning criteria. When assessing a patient's readiness to wean from mechanical ventilation, there are some parameters that must be met. The first step for considering weaning requires the resolution of the acute phase of the disease that caused mechanical ventilation in the first place. Then the patient must have an adequate cough with manageable secretions, and they must be hemodynamically stable. If so, then you can proceed to check the other criteria, which include acceptable ABG results, frequency, tidal volume, vital capacity, minute ventilation, maximum inspiratory pressure or negative inspiratory force, maximum expiratory pressure, rapid shallow breathing index, acceptable oxygenation, acceptable PF ratio, acceptable shunting, acceptable alveolar to arterial oxygen gradient, static compliance, airway resistance, dead space to tidal volume ratio, and the patient must pass the spontaneous breathing trial. And again, the acute condition that initially required mechanical ventilation must be resolved or significantly improved in order for weaning to be successful. And just a reminder, a spontaneous breathing trial is the primary test used to assess a patient's readiness for weaning from the ventilator. It involves a period of time where limited or no support is provided by the ventilator, during which the patient's vital signs and respiratory status are closely monitored. The trial is considered successful if the patient is able to maintain adequate oxygenation and ventilation without any significant distress. If the patient does not meet the required criteria, they should be placed back on the ventilator and given additional time to rest and recover. And that leads to the next topic, which is extubation. Extubation is the process of removing an endotracheal tube from the patient's trachea and discontinuing mechanical ventilation. The decision to perform extubation is based on the following factors: the patient's ability to protect the airway, the ability to maintain adequate respiratory function, their ability to manage secretions, their ability to maintain adequate oxygenation, their ability to maintain hemodynamic stability, and their ability to cooperate with the medical team. If the patient meets the above criteria, extubation would be indicated and the endotracheal tube can be removed. This procedure is typically performed by respiratory therapists. And since I've been spending this entire time talking about mechanical ventilation in adults, I feel like I also need to talk about neonatal mechanical ventilation, which is the process of delivering positive pressure to an infant's lungs for breathing support. Just like adults, this would be indicated when the infant's respiratory efforts are insufficient to maintain adequate oxygenation and ventilation. However, mechanical ventilation in newborns is different than in adults due to obvious anatomical differences. For example, infants have much smaller lungs, therefore they will require smaller tidal volumes. Additionally, the pressure needed to ventilate a neonate's lungs is much lower than in adults. These primary differences in pulmonary mechanics require special considerations when providing mechanical ventilatory support. So, as you can see, mechanical ventilation is a wide-ranging, complex topic. However, it's one that must be understood by medical professionals, especially respiratory therapists. And to be honest, this video only scratches the surface of all the information that is required for you to know. But we do have a guide on our website that goes into more detail and breaks it all down in a simplified way. So definitely check that out if you want to learn more. I will drop a link to it below this video down in the description. But if you want to support the channel, I would greatly appreciate it if you liked and subscribed. And there should be some other helpful videos popping up on your screen right about now that I think you'll enjoy. And just a quick reminder, we are not doctors. This video is for informational purposes only. Thank you so much for watching. Have a blessed day. And as always, breathe easy, my friend.